Thank you very much for that excellent talk. As somebody who's here in academic medicine who has quite a few non-clinical days being pulled every month, I am very appreciative of that talk, Dr. Rathmel. Our next speaker is Dr. Dan Sessler. Dr. Sessler attended medical school at Columbia University and subsequently completed pediatric and anesthesia residencies at the University of California, Los Angeles. He's currently Vice President for Clinical Research at UT Health in Houston. Dr. Sessler has published more than 1,000 full papers, including 36 in the New England Journal of Medicine, Lancet, and JAMA. His papers have been cited 70,000 times in peer-reviewed articles per Scopus, making him the world's most published and cited perioperative investigator. He has given more than 500 invited presentations, including more than 24 eponymous lectures. Dr. Sessler has been a principal on co-investigator on grants totaling $100 million. He founded and directs the Outcomes Research Consortium. The consortium is the world's largest anesthesia research group. It's my pleasure to welcome to the podium Dr. Sessler.
In 1760, Voltaire wrote that physicians poured drugs of which they knew little for diseases of which they knew less into humans of whom they knew nothing. For the next 100 years, from our perspective, nothing whatsoever happened because anesthesia had yet to be invented. In fact, exactly 100 years later, the Harvard professor Oliver Wendell Holmes wrote, "If all our drugs could be sunk to the bottom of the sea, it would be all the better for humans and all the worse for the fishes." That was a pretty accurate statement in 1860, but things were about to change because anesthesia had just been invented. Over the next century, anesthesiologists decreased perioperative mortality, intraoperative mortality, by a factor of 100. Since my residency, intraoperative anesthetic mortality has decreased by another factor of 10. This is a remarkable accomplishment. No other specialty has remotely reduced mortality by a factor of 1,000. It's something we all should be proud of. There is a problem, though, and the problem is postoperative mortality. Intraoperative mortality is now so rare that it's hard to quantify. In contrast, somewhere between 1% and 2% of surgical patients die within 30 days of surgery. This is way higher than in a non-operative month. 1/3 of these deaths occur during the initial hospitalization that is under our care in our highest level healthcare facilities. Postoperative mortality is 140 times higher than intraoperative mortality. Let me put this in perspective for you. Postoperative mortality is the 3rd leading cause of death in the entire world. We lose a lot of patients after surgery. A reasonable question then is, what's killing people? And the answer is myocardial injury. Myocardial injury after non-cardiac surgery, abbreviated MINS, is common, silent, and deadly. More than 90% of myocardial injury after non-cardiac surgery is asymptomatic. And that's why this syndrome has been missed, and it's still missed way too often. These are typically type 2 infarctions. They're supply-demand events They're different from your typical type 1 infarction that results from plaque rupture, and they present differently. They present asymptomatically. Now, you might think, oh, it's asymptomatic, can't be that serious. But you would be wrong, because it turns out that type 2 infarctions are actually more deadly than type 1 infarctions. Let me put this in perspective for you. A surgical patient with an asymptomatic troponin elevation postoperatively is more likely to die than a patient who shows up in the emergency department with crushing chest pain. The fact that it's asymptomatic doesn't mean that it's not serious. It is. 20% of patients with myocardial injury are readmitted within a month. 8.5% have a myocardial infarction, cardiac arrest, or are dead in 30 days. And importantly, 1 in 7 will have a major vascular event within 16 months. And these are nearly all reinfarctions, classic type 1 infarctions. If you don't measure troponin, you won't know about these events because 90% are asymptomatic. So you need to measure troponin, and mortality is a very strong function of troponin concentration. But because they're asymptomatic, if you don't measure troponin, you simply won't know. But what this shows is that at high troponin concentrations, lethality is very high. But even the smallest increase in troponin more than triples 30-day mortality. And it's not just 30-day mortality. Patients who have troponin elevations continue to have high mortality for a year and actually beyond a year. It's the reinfarctions that are killing people. This has led 4 different professional societies to recommend troponin screening in moderate to high-risk patients. Basically, everyone who has looked at this seriously says, yes, if you don't measure troponin, you won't know about these events. Myocardial injury is the leading cause of death after surgery. Death after surgery is the 3rd leading cause of death in the world. You don't measure troponin, you miss all of that. Now, a difficulty is that none of these societies and guideline organizations very carefully defines what moderate and high risk are. So I'm going to give you my simple explanation, which is that you should measure troponin in inpatients over the age of 45 who have at least one cardiovascular risk factor, and in all inpatients over the age of 65. With high sensitivity troponin, which is what nearly everyone uses, you need to measure troponin preoperatively. And the reason is that something like 20% of surgical inpatients have elevated preoperative troponins. This does not mean that they're having a heart attack. You do not need to send them to the emergency department. It's a marker of baseline cardiovascular risk. But if you don't know what the preoperative concentration is, it's hard to interpret the postoperative concentrations. So get a value preoperatively, and then for at least the first 2, but preferably 3 postoperative mornings. Now, I wish I could give you a simple threshold. Okay, the threshold for troponin is something, and if it's above that, you have myocardial injury. The trouble is that there are 2 different generations of troponin kicking around, and then there are various brands of troponin. So troponin T is a Roche brand. It's exactly the same all over the world. Troponin I is generic. Lots of companies make troponin I. So we know the threshold for Abbott and Siemens, which are the most common, but for others, you'll have to negotiate with your lab to find out what the threshold should be. Then the question is, what do you do with an elevated troponin? After all, we shouldn't be doing tests if you can't do anything about it. But it turns out there's lots that you can and should do for an elevated troponin. First thing you should do is consult cardiology. Now, fair warning, when you consult cardiology, they will probably come by, determine that the patient is asymptomatic, write a sarcastic note, and leave. Because the cardiologists don't understand this, despite the fact that we have published in their literature. They still largely don't understand it. Nonetheless, it's important that you get these patients connected with someone who can provide long-term care. Because these patients are at 30-day risk, but what really kills them is reinfarctions later, months, years later. And so you need to get them plugged in with somebody who can provide chronic care. They've had a heart attack. We call it myocardial injury after non-cardiac surgery. It's a heart attack. So they need to be treated as if they've had a heart attack. It's not something we can do because we don't follow our patients chronically. So arguably the most important thing you can do is get these patients to somebody who can provide chronic care and make sure they understand that this patient has had a heart attack and needs to be plugged into heart attack type treatments. Almost all should be put on aspirin. They should be considered for statins and ACE inhibitors. If they are hypertensive or tachycardic, this would be a really good time to get that under control. Somebody needs to have a discussion with his patient. Hey, you had a heart attack. Your chances of having another heart attack are high, but there are things you can do to reduce your risk, like smoking cessation, exercise, healthful eating. And then finally, you can consider anticoagulation. This is based on the MANAGE trial. We randomized 1,700 patients, all of whom had myocardial injury, to either anticoagulation or not. Anticoagulation was highly effective. It reduced the risk of reinfarction by almost a third. This is actually not surprising because anticoagulation also helps for conventional myocardial infarctions. Let me go on now and talk about risk prediction. So I think every anesthesiologist on the planet asks patients, can you climb a couple of flights of stairs? And if the answer is, yes, I can do that, we all feel relieved. The trouble with that is that it turns out that exercise tolerance is actually not very helpful. First, because patients have a poor ability to describe their exercise tolerance, and second, because we have a poor ability to understand what they're telling us. But it gets worse than that, because even formal cardiopulmonary exercise tolerance testing is not predictive for cardiac events after surgery. Stress echo and CT angiography are common. After all, we all, I think, send lots of patients off for stress echo. Turns out that both of these tests overestimate risk, and they actually worsen risk assessment. That is, if you do a revised cardiac risk index, you will know more about your patient than if you send them off for a stress echo. You're more likely to have the right answer by not doing these tests. The trouble with the revised cardiac risk index is that it overestimates the risk of myocardial infarction by about 25%, and it assigns about half of all patients to intermediate risk. Well, that's not very helpful. As a clinician, intermediate risk doesn't really tell you a lot about how to manage this patient. So, is there something better? And the answer is yes. NT-proBNP, or just plain BNP, are way better than anything else. This is an inexpensive test. It's available on a point-of-care basis, and it turns out to be very highly predictive. Now, when you're talking about predictions, there are lots of things that predict an outcome. After all, age predicts almost every sort of badness. So your question is not, is something predictive? Your question is your predictive measure adding information to what you already have for free? And the answer for NT-proBNP and BNP is unequivocally yes. Compared to the revised cardiac risk index, NT-proBNP correctly identifies 16% more high-risk patients. That is, it reclassifies 16% of the patients deemed intermediate risk correctly into high risk, and simultaneously, it correctly identifies 15% more low-risk patients. So correctly takes patients from this intermediate risk group and tells you actually they're low risk. So you have much more information if you do NT-proBNP than if you do anything else. So highly, highly recommended test. Unfortunately, there is currently no known safe prophylaxis for postoperative myocardial infarction. The first test, P.J. Devereaux, was POISE-1, 8,000 patient trial randomized to beta blockers versus placebo. The beta blockers worked in the sense that they reduced myocardial infarction by 30%, highly statistically significantly. However, the beta blocker also caused hypotension and strokes and actually increased overall mortality. So beta blockers work, but they're not safe. The next trial was Enigma 2, and in this trial, we randomized 7,000 patients to nitrous oxide versus nitrogen, the hypothesis being that avoiding nitrous oxide would reduce the risk of myocardial infarction. It did not, had no effect whatsoever. The next trial was POISE-2, again, P.J. Devereaux and many of us did this trial, 10,000 patients, factorial randomization to clonidine and aspirin. Aspirin did not reduce the risk of myocardial infarction but caused life-threatening bleeding. Clonidine did not reduce the risk of myocardial infarction but caused bradycardia and hypotension. And then the most recent large trial was the tranexamic acid portion of POISE-3, 9,500 patients. Tranexamic acid had no effect on myocardial infarction, either positive or negative. So I don't want to leave you with nothing. So I'm going to talk about hypotension now. So these are results from the Cleveland Clinic. And look at the left-hand side, please. So this is the risk of myocardial injury as a function of the lowest 3 or 10 minutes of blood pressure during the entire case. So first thing you see is that the 3-minute curves and the 10-minute curves look almost the same. And the second thing you will notice is somewhere around 65 millimeters of mercury, mean arterial pressure, the curve starts to shoot up. It's actually going up a lot faster than you think because the y-axis is on a logit scale. So what looks like a linear increase here is actually an exponential increase. So somewhere around 65 millimeters of mercury, on a population basis, the risk shoots up. On the right-hand side, what I plotted is the change from baseline. And the reason we did that is that when I present the left-hand results, people very reasonably ask me, well, what about patients who start out hypertensive? Should I be looking at their change from baseline? So that's what's plotted here. And notice that the curves look identical, except that the threshold is at 30% below baseline. So all of us were taught keep the blood pressure within 20%. Well, turns out 30% would be a more accurate number. But if you want to use 30% reduction from baseline, you can. But it turns out that using absolute pressure is just as predictive as using the change. And it's a lot easier to use an absolute pressure because we often don't have a good clinic baseline pressure in patients. And, of course, you don't need to do any calculations. Not shown here, but the results look nearly identical for acute kidney injury. There are now quite a number of trials about blood pressure during surgery. So the very first was Fouché, a tiny study, fewer than 300 patients, very high-risk patients, somewhat strange protocol. And he reported that controlling blood pressure, preventing hypotension, reduced the risk of a complicated composite of systemic inflammatory disease and organ injury by 25%, which is very encouraging. The trouble is that it was followed by a study by Patrick Warner, about 450 patients, showing no benefit from targeting a higher rather than a lower blood pressure. And then POISE 3 had a blood pressure component. So in about 7,500 patients were randomized to a high blood pressure above 80 millimeters of mercury or allowed to go down to 60 millimeters of mercury. There was no difference in that study. Furthermore, there are 2 other unpublished trials, each with more than 1,000 patients, showing that keeping a high blood pressure versus allowing blood pressure go down to 60 or 65 millimeters of mercury doesn't change the outcome. So the trials are not really supporting the observational data. But folks, at some level, hypotension causes organ injury. That is beyond question. The only question now is what the threshold is. So we don't really know, but it's probably on the order of 60, 65 millimeters of mercury. Just as a point of interest, we did this study where we used machine learning and artificial intelligence systems to identify the causes of intraoperative hypotension. Not terribly surprisingly, vasodilation and hypovolemia turned out to be the most common causes. So that's what you should be thinking about when you see hypotension. What's interesting is that this logic, this machine learning, could be incorporated into monitors. And I think the monitors of the future will not just tell you what the blood pressure is, they will also tell you what the most likely cause of hypotension is. In contrast to hypotension, hypertension hardly matters at all. If you look on the left, the bottom curves, the 3 colored lines, are cumulative 5, 10, 30 minutes of the highest systolic pressure. And you'll notice that the lines are absolutely flat. The insert is the hypotension curve. And you see how different they are. Hypertension, the curves are flat. For hypotension, they shoot up. So I'm not saying that there's no level of hypertension where you'll intervene. At some point, sure, you need to intervene. But hypertension, despite what many of us were taught, turns out to be essentially harmless during anesthesia. If you intervene to treat hypertension, please do it gently, because if you treat hypertension and you cause hypotension, you're probably not helping your patient. On the right, we have the same thing for acute kidney injury. Again, curves absolutely flat. Next, I want to talk about tachycardia, because as with hypertension, many of us were taught that tachycardia is terrible and has to be avoided at all costs. All patients have to get beta blockers. Remember this? Okay, as far as we can tell, tachycardia is unrelated to cardiovascular outcomes. And that's true at a heart rate threshold of 80, a threshold of 90, a threshold of 100, and when we use the highest heart rate that patients had at any time during surgery, there's just no signal whatsoever. So once again, I'm not saying that there's no heart rate that you should treat, but if you treat tachycardia, once again, please do it gently, because the tachycardia is probably harmless. If you cause hypotension, you're probably not doing your patient a favor. Now, the problem in the room is that the risk is high on surgical wards. We take very good care of patients for a few hours during surgery, and then we drop them on surgical wards where they're barely even monitored, much less managed. As far as we can tell, heart attacks and myocardial injury occur postoperatively. They don't occur intraoperatively. They occur postoperatively. 90% of myocardial injury after noncardiac surgery occurs within 2 postoperative days. 30% of the deaths as I said, postoperatively occur within the initial hospitalization. So surgical wards are a very high-risk environment that currently pretty much nobody pays attention to. The surgeons come by, see the patients for 10 minutes in the morning, they deal with surgical issues. Maybe somebody from anesthesia goes by and does a pain consult, but nobody's looking at the whole patient and really managing them. But it's a very high-risk period. Hypoxemia and hypotension on surgical wards are common, profound, and prolonged, and they're mostly missed by the nurses. And let me be clear, I am not blaming the nurses here. These events are missed because the nurses measure blood pressure and heart rate and vital signs intermittently, typically every 4 to 6 hours, and many of these events occur between measurement points. It's not that the nurses are doing something wrong, it's a system problem. So this is an example. So this is blinded saturation. So we were just measuring saturation continuously in some 1,500 patients, blinded to clinicians. So nobody was intervening for this. This is a little sobering. By the second postoperative day, more than 10% of all the measurements we made had a saturation less than 90%. Okay, patients sitting on a surgical ward at 85% saturation isn't going to drop dead. That's not what I'm saying. But it's also not a patient who has a whole lot of reserve for something going wrong. But this is absolutely common. Not only it's common, it's undetected with the way we currently measure vital signs. Nurses missed 90% of these events. And again, this is not a nursing problem, this is a system problem. Ward hypotension is also common. So specifically, 24% of the patients we measured with continuous blood pressure, again, blinded to clinicians, had mean arterial pressures less than 70 millimeters of mercury for at least a half hour. 70 millimeters of mercury is low for a patient on a surgical ward. And it gets worse because almost 20% of the patients had at least 15 minutes with a mean arterial pressure less than 65 millimeters of mercury. That's critically low on a surgical ward, but happens all the time. And once again, it's mostly missed by the nurses. The reason I'm talking about this is that postoperative hypotension matters. So this is a reanalysis of POISE 2. And what it shows on the top line is that intraoperative hypotension is strongly associated with myocardial infarctions. That's true for the remaining day of surgery also. But it's also true for the first 4 postoperative days. Patients who are hypotensive after complex statistical adjustment are still more likely to have myocardial infarctions. And these were full infarctions in this study. So to summarize here, myocardial injury is common, deadly, and it's mostly silent. If you don't monitor troponin, you will miss 90% of these events. Patients at moderate to high risk should have troponin monitoring preoperatively and for at least 2 postoperative days. Use NT-proBNP if you can for risk stratification. It's better than everything else. There's currently no known safe prophylaxis for postoperative myocardial infarctions, but there are strong associations between hypotension and, as I said, at some level, hypotension causes organ injury. Folks, myocardial injury after non-cardiac surgery is the leading cause of death after surgery. The 30 days after surgery is the 3rd leading cause of death in the world. We have an opportunity to help. Carpe diem. Seize the day. Thank you.